Hi, thank you for joining us again. I'm Dr. Ferdinand, the Gerald S. Berenson Chair in Preventative Cardiology at the Tulane University School of Medicine in New Orleans, Louisiana. And I'll let my colleagues introduce themselves. First, we'll go with Ms. Ross and then Dr. Jackson. Ms. Ross?
Thanks, Dr. Ferdinand. I'm Laura Ross. I'm the director of the Prevention Clinic at Park Nicollet Heart and Vascular Center in St. Louis Park, Minnesota. Thanks for having me today.
Also, Dr. Ferdinand, I appreciate it and thank you for the invitation. I'm Dr. Larry R. Jackson, the second associate professor of medicine and a cardiac electrophysiologist at Duke University Medical Center.
Great. Now, when we had our conversation in the symposium, we talked a little about the AF paradox. And that is, you have a population, high risk factors for atrial fibrillation, hypertension, obesity, especially in Black females, diabetes. But when you look at some of the cohort studies, there's less diagnosis of atrial fibrillation. So I ask you first, Ms. Ross, and then Dr. Jackson, feel free to come in. Why do you see this? You think it's just a lack of diagnosis due to a lack of access to care? What are we missing?
I think it's probably multifactorial. There's a lack of awareness. There's a different presentation in symptoms. There's a discrepancy in how patients might describe their symptoms. There might be a change in how often they're seeing providers or if they don't have a good relationship with a primary clinician. So I think those are all factors that can contribute. And despite the lower incidents that we have documented, a significant increase in the actual outcomes we all care about with more strokes despite having a lower diagnosis. So that would be my take. How about you, Dr. Jackson?
Yeah, I agree. I think it's complex and probably rooted in multifactorial causes. The additional things that I would comment on, in addition to Ms. Ross, would be the survivorship advantage that you would see over whites versus Blacks. They're living longer, more likely to develop and have prevalent atrial fibrillation. And also a potential genetic component. Now, I admit this hasn't been well teased out, but maybe there is something protective in Blacks with respect to atrial fibrillation, or maybe something that is deleterious at the epigenetic or genetic level in whites that is causing them to have more atrial fibrillation. So once again, Dr. Ferdinand, a complex issue, but I think between Ms. Ross and I, we've sort of articulated the reasons that why we may be seeing this paradox. And to Mrs. Ross's point, it is in fact a double paradox. So worse outcomes, even though there's a lower prevalence of atrial fibrillation, for example, in Blacks, but clustering higher risk factors.
Well, those are really great points. And those outcomes should drive us to look for that atrial fibrillation, maybe with extended ECG monitoring or even implantable loop recorders. We might be missing it. We talked about the social determinants throughout the symposium where people work, live, play, and pray. And Ms. Ross, you addressed that probably more profoundly than either myself or Dr. Jackson. Dr. Jackson, I know you also know about that. So let's talk about the social determinants. How important is that?
So it's so important. I think, we think about things as Black or white, literally and figuratively, but knowing someone's education level, what their income is, whether they work days or nights, their access to green space, and even pollution has been associated with a higher risk of AFib. So more urban areas, but rural areas have their own outcomes that we need to worry about. There's a higher risk of dying with atrial fibrillation and having strokes in more rural areas. And so how do we bring access to care to all of these areas and our patients who are experiencing social determinants of health? And I think another aspect we may get to later too is English as a second language and health literacy is a large social determinant of health. And so are we meeting patients where they're at and also communicating with their caregivers about the importance of compliance and what outcomes could be if what are their barriers to care? And so it is a complicated picture, but I think we no longer can just have patients come in to see their clinician and say, this is what you should do and expect that that's what's going to be done. And in fact, we need to address the whole patient in front of us.
Now, Dr. Jackson, you're at a major academic medical center, and people would tend to think that it's a silk stocking where you see only fancy patients, but I know that's not the case. You see patients who are impacted by these social determinants. How important do you think it is in establishing care?
It's of the utmost importance, Dr. Ferdinand. And I think we should all understand that these mid-level determinants, these social determinants, are really rooted in racism and poverty and discrimination. And I think to Mrs. Ross's point, we are not doing enough studies to associate these social determinants of health with atrial fibrillation. So Ms. Ross spoke to the neighborhood and the physical environment interaction, the social and the community context and the support, how our healthcare systems are playing a role in AFib management, health literacy, education, and economics. So I think there are very few studies looking at social determinants, particularly in the United States. And that matters because our population is so heterogeneous and there's a wide gulf in the outcomes between racial and ethnic groups and white populations. So I think even at a major academic institution like Duke University Medical Center, you will see anecdotally where these social determinants are at play and how they affect people's management and outcomes of atrial fibrillation.
Great point. Now, one thing we talked about was the DOAC, and I spoke about the need to utilize DOAC. There's a disparity in terms of less DOACs are used in African Americans than in general population, even with indication. But Dr. Jackson, you pointed out to me that you still sometimes use warfarin. Can you refresh for our audience when you think warfarin may still be the indicated drug of choice for an anticoagulant?
Yeah, it's a great point. And I will reiterate to your point, Dr. Ferdinand, the guidelines do steer us toward direct oral anticoagulants, but sometimes they are cost prohibitive. And we know that warfarin, while being the gold standard, is significantly cheaper than the direct oral anticoagulants. And then that matters to a select portion of our patient population. So we have to keep that in mind. The other two minor points I would mention is that there are several studies that show that the adherence or the persistence is actually better for warfarin than the direct oral anticoagulant medications. So I think there's something about continual touch points, whether that be speaking with a physician or a pharmacist, getting that INR check, that is promoting persistence of therapy of warfarin over the direct oral anticoagulants. So I think every patient is different, and we have to consider every patient on the individual level, specifically in terms of adherence and more importantly, maybe in terms of cost of medication.
Can I look at it another way? Not contradicting anything you said, because what you said is absolutely correct. But perhaps we should not forget, even once we put that patient on the DOAC, they still need to be monitored closely.
Absolutely, absolutely.
All right, now one of the things we talked about was communicating with patients. Ms. Ross spoke of that. She works directly with patients and overcomes any barriers to their understanding. How important is that in your daily work, Ms. Ross? And then Dr. Jackson, you can talk about some of the tools that you use at Duke in order to educate your patients.
I mean, that's the utmost importance. We can write whatever we want in our note, but if it's not directed through the patient into their caregivers. So I make sure I always use Google Translate if English isn't the person's first language to put on their after visit summary. I ask if there's a person at home who I should be calling or who manages their medications that I can discuss that with. Sometimes I'm on the phone or I'll have my nurse call the pharmacist, say, are they filling their medications? What can we try to get what the cost is, or push that pharmacy benefit button on our EMR to help find out if it's on the formulary to try to circumvent some of those potential barriers to care. And so I think once patients understand, I mean, one of the studies we talked about during our conference was that only 30% of patients actually understood what a stroke was and that was a possible complication of atrial fibrillation. And so I think if we're not doing a good enough job explaining what the potential outcomes of this rhythm, which they may or may not have symptoms from, there's less impetus to take the medications that could be very expensive. I think the other thing, which is probably a broader topic to talk about, is the study we talked about during the conference about when a DOAC became on the Canadian formulary, the discrepancy between stroke outcomes between Black and white Canadians became equal. And so what, as a system, can we do in this country to try to help even things out a little bit more for those outcomes?
You know, Dr. Jackson, I've been practicing for many years, and at one time we thought that atrial fibrillation was kind of a nuisance arrhythmia. How do you communicate to your patients that this is more than just a finding on an ECG?
Yeah, very important point, and I appreciate the tenor of the question, Dr. Ferdinand. I think we have to speak directly to our patients about what atrial fibrillation is, right? It's the most common abnormal heart rhythm in the world, and it is associated with significant morbidity and mortality, as you know, from not only heart failure and thromboembolic events, but an increased risk of dying. And I think patients have to know that up front. And I think communicating those risks in plain language is very important. I know we get carried away sometimes in cardiology and speaking about percentages and things of this nature, but communicating that, hey, while this is a nuisance arrhythmia, it can cause some symptoms, there are some real issues around quality of life and then survival associated with atrial fibrillation. And I think once you frame the conversation in that way, it really makes sure the patients understand what atrial fibrillation is and is not, you can have a more informed conversation about some of the treatment strategies that we talked about during the symposium.
I think one of the most important messages for patients is the concept of risk. I use the guy who's on the interstate going 110 on a motorcycle feels great, very high risk. So we have to kind of communicate to our patients, when you agree, Dr. Jackson, even if they feel okay, if they have an appropriate CHA2DS2 score, and if they have appropriate documentation of atrial fibrillation or high risk, they need treatment, regardless of whether or not they, quote, feel bad.
I would totally agree. And I think it's challenging for patients sometimes to understand that, hey, this rhythm that I have, while I may be doing okay with it in the short term, it is the long-term consequences that we are really trying to prevent. And I think, once again, conversations around how atrial fibrillation is a disease, right? It is a disease process that for the better part of it, we don't necessarily know how to cure. So I think communicating short-term and long-term risks and the benefits of some of the treatments we offer are of vital importance.
You know, I think this conversation is representative of the best in team-based care. And we at the Cardiometabolic Health Congress like that concept, where you have providers, clinicians at different parts of the team come into play to help the patient. So perhaps looking first at Ms. Ross and then Dr. Jackson, give me just a 30-second take-home message, the one thing that you want your colleagues to remember about our conversation.
Great question. I think, like you said, teamwork, trying to involve the patient as the center spoke of that team and kind of what are your symptoms, paying more attention to those patients with social determinants of health to tease out that they might be having asymptomatic AFib, using digital technology if that's available, smartwatches, those sorts of things, and then to not dismiss symptoms that could represent something more important, and then to get on the patient's level when you're providing education, and whether that's more rudimentary to just talk about the long-term plan, like Dr. Jackson said, what are your long-term goals? You know how we can help you get there is to try to take these medications that can keep you independent and living a vibrant life.
Great message. Dr. Jackson, you have the last word, a take-home message for our audience.
I think the audience should understand AFib requires a holistic approach. So we're speaking a lot about team, but it's also interactions with primary care around nutrition, around obesity management, around the management of those risk factors that we all see and deal with every day, from hypertension to diabetes. It could potentially involve, genetic counseling and genetic screening, understanding the role of social determinants and how that plays a part in access to care and challenges in getting medications. So it is a holistic approach. It is sort of team-based care. It is integration, really, what we need to affect change in atrial fibrillation. And I think this is the significant improvements we need in our healthcare system if we're going to see better atrial fibrillation outcomes.
Well, I appreciate the opportunity to speak with you guys, and I look forward to working together in the future. We've been addressing some of the disparities in the diagnosis and treatment of atrial fibrillation, the impact of the social determinants, team-based care, patient education, and shared decision-making. I think we've learned a lot from listening to you today. Thank you again, both, for your participation.
Thank you, Dr. Ferdinand.
Thanks. Thank you, Dr. Ferdinand and Dr. Jackson.